80%, and there were sternal retractions. So in this case, we look around, we see the ventilator graphics. So the screen we have all seen in our day-to-day practice, and let us see what does it tell in this case. So if we see the pressure waveforms, the peak inspiratory pressures are being met. There is the peak and pressures, and the map seems, if forms, reduced significantly. The screen, the tidal volume which is being delivered is just 1.2, and it's almost 50% that I would expect in such a baby. If we see the resistance is 239, so resistance normally in a newborn is around 20 to 30 centimeters per liters per second. So it's almost 100 times more in this case. We see the minute ventilation, obviously the tidal volume which is not being met. So the minute ventilation is also significantly reduced. We do not see a leak. So with this information, we inspect the baby. So on inspection, there has been no endotracheal tube obstruction. The tube appears to have slipped to 8 centimeters at the lips. So always when you are examining the baby in cases of acute deterioration, always see where the tube has been fixed. So in this case, it is at 8 centimeters and it is far below where it should have been. On auscultation, there has been reduced air entry on the left side. So now in the chat box, I would like to see what your answers as to what this condition could be. I would like the participants to join in the discussion.
You move to the right side.
Yes. So yes, this is an unplanned advancement of the ET tube. The ET tube seems to be in the right main bronchus. So in this case, we just simply moved the tube little up, fixed it at around 6 to 6.5 where it should have been, and the baby improved. Moving to the next case scenario. So this is a 2-day-old infant born at 26 weeks gestation and was on the assist control mode. The nurse says that she was changing the infant's nappy when the baby started desaturating, and despite increasing the FiO2, she continued to deteriorate. We see the monitor, the SpO2 is 75%, the baby has bradycardia, and the baby and ventilator, they seem to be asynchronous, and the ventilator seems to be cycling like at 120 per minute. So now again, we see the ventilator screen. And we see in this case, again, the pressures are being delivered. So the PIP is being reached, the PEEP is being maintained. Interestingly, now in the flow curves, we do not see the expiratory flow. And also in the volume curves, the volume which has been reached during the inspiration abruptly falls. The parameters which are expressed on the screen shows us the rates of 102. So a baby which is breathing like almost normally a baby would breathe at around 60, and this is breathing at 102. So it gives me an idea that there has been some sort of auto triggering that is happening. Again, the tidal volumes are not being met. The resistance is high. As the tidal volumes are not met, the minute ventilation also seems to be a little low, and we see 100% leak. Just with this, I would like to give you a little idea of the various loops which are seen on the ventilator screen as well. So this is a very common pressure volume loop, and this shows us that the pressure fails to reach the end and ends abruptly. This is the imaginary line which is drawn. So this shows that there has been a leak. Similarly, in the volume flow graph, the loop also, the expiratory loop ends prematurely, indicating that there has been some sort of leak. So on inspection, again, we do not see any ET tube obstruction. The tube is fixed at the correct position. There is minimal chest movements, and on auscultation, there is bilaterally reduced air entry. So I would like somebody to answer. So what do we suspect in this case? Anyone can unmute themselves and answer.
ET tube will be out.
Yes. So this is an unplanned extubation, or there has been a ventilator circuit detachment. So mostly this is a case of unplanned extubation. The baby was re-intubated and the baby improved immediately. So now in this slide, let us try to recognize some of the clinical signs that give us a little knowledge and idea of what is wrong with the ventilated baby. So deteriorating baby may show a reduced or a sudden drop in the SpO2s. There can be heart rate variability ranging from tachy to bradycardias. If the deterioration has been since a long time, then there will be associated hypotension. The FiO2s and the pressure requirements will subsequently increase. If you do an inspection, there will be reduced chest movements or sometimes asymmetric chest movements. The color changes would be evident and the ABG may show a respiratory acidosis. So always, you should spend time at the bedside examining such a baby, and along with it, it's very important to check the surrounding. The surroundings have the ventilators with its massive screen showing us all the waveforms, the parameters that are being delivered, more so the alarms. Also, there is a pulse oximeter which is connected to the baby. So you should always see the trends in such cases. The units which are using EtCO2 may even look into the EtCO2 readings and get an idea. And the various ABGs or anything which is available bedside may also give an idea on what is wrong with the baby. So it's very important to act early, but act systematically. So in any deterioration, something wrong can happen at 3 stages. Number 1 being the baby itself. So it could be the primary disease has shown any progression or further worsening, or there could be any complications of the primary disease that have developed. So if you see a case of RDS, so a baby, maybe at 10 to 12 hours, the baby would have worsened further, or there can be some added complications like some air leaks or a pulmonary hemorrhage, or there can be like an overriding infection, sepsis, VAP, and in certain cases, even pulmonary artery hypertension. The second thing is the ET tube. So something which is wrong with the ET tube, it can be in terms of a blocked or a dislodged ET. And thirdly, the ventilator with all its massive circuits. So always try and look into the circuit as well as the ventilator, because something may be wrong in the settings or the ventilator delivery parameters. So earlier, whenever there is an acute deterioration in the NICU, it stood synonymously with the DOPE approach. And all of us would be well aware of what DOPE stands for. So here the D stands for a displaced ET, O for an obstructed ET, P for a pneumothorax, and E for equipment failure. So whenever there was such a case, our mentors always told us to one by one go through the dope parameters, disconnect from the ventilator, use a TP's resuscitator or an AMBU with 100% oxygen and see if the baby improves. After this came the dope SIP approach, where SIP stood for sepsis, IVH, and PTA. And lately, in 2021, NNF came up with the bold PEEP approach. So this is a more elaborate form. And here we have a lot of things which were taken into consideration. Starting from B, which is the bad or worsening lung disease. And this takes into consideration the baby or the infant factors. It could be the progression of RDS or the complications like hemorrhage, atelectasis, collapse, edema, evolving air leak, or inadequate lung recruitment. O again here stands for the obstructed ET tube. The tube can be obstructed with secretions, plugs, mucus plugs, blood clots, or it could only be kinged. L is a long ET tube, which is either short or long of ahead of the main area where it should be lying. So it could be a tracheal intubation, very high up tracheal intubation, or it could be a right main bronchus or a unilateral bronchus intubation. D stands for a displaced ET tube and takes into consideration the accidental extubations, partial extubations, and malpositions where the ET is lying in the esophagus. P stands for the pneumothorax and the various other air leak syndromes. E for our equipment failure, and here ventilator and circuit disconnections are taken into considerations along with problems like oxygen supply failure or a humidification. And very importantly, the EP stands for equipment patient asynchrony. So something as little as an infant fighting the ventilator, in pain, agitation, inadequately sedated, may again lead to an acute deterioration. We will discuss this bolt PEEP approach later in subsequent slides as well. So what do you think? Is dope and bolt PEEP enough? No, with the current ventilator technologies, it's very important to take everything into consideration and look for signs which the baby gives us and also which the machines tells us. So it's important to anticipate, process this information rapidly, and get into a diagnosis. So let us see the various tools for assessment which are there in the NICU and which can help us reach to a conclusion. So coming to the first, so every baby in the NICU has the pulse oximeter attached. So whenever we see an SpO2 which is below the the target SpO2, we should always think of the first things first. Look at the baby, look at the pulse oximeter probe. Something as little and simple as a displaced probe may give us a false reading of the SpO2 and the heart rate. So it's very important to trace the a desaturation which is associated with bradycardia is usually suggest that the problem is far more bigger and it requires very prompt attention. The second most important tool for assessment is the history. So always back to your roots. Check the NICU chartings. See if there has been an event prior to desaturation. Maybe the infant was handled, or maybe was the handling of the ET tube. Maybe there was significant secretions and the baby required a lot of suctioning. maybe the baby is having seizures, because again, such a baby will have autonomic instability. And also take SIP, that is sepsis, IVH, and PDA into consideration. The next very important tool for assessment is the ventilator, and not just the ventilator. Ventilator with its alarms, numerical parameters which are being displayed, and the waveforms. So let us see the ventilator alarms. And post this presentation, I would really be very happy if we now don't just mute the alarms of the ventilator and start addressing the issue in hand. So it's very important to listen to the alarms. So let us see the common alarms which the ventilator usually gives us and how to rectify them. So a very common alarm is the flow sensor alarm. So this is commonly indicates that the flow sensor is not working adequately, and that is why the tidal volume which is being set may not be delivered. So this can just be the water in the flow sensor or the complete failure of the flow sensor. In such cases, we should first recalibrate the flow sensor and change it if required. The apnea alarm. So many of us would always think that the apnea alarm simply indicates that the baby doesn't have its own respiratory efforts and is being treated with all the mechanical backup breaths, but it's not just that. The apnea alarm may sometimes just indicate that the tube is not in its correct position and is either displaced or obstructed. Thirdly, the set VT not reached, and it is again a very common alarm which we go on muting. So it's important to know that the VT is being determined by the PIP max that we are setting. So in a case, when we are using the VT mode, the baby decides as to how much pressures the baby needs to do a set tidal volume and reach it. So in a case where we are setting the maximum PIP low, so here the maximum PIP would be delivered and still the baby may not be reaching the set VT. So we should always keep the set PIP max to around 20 to 22, so that in cases if there is a worsening of the lung disease, the baby can determine how much PIP they have to take. So again, it indicates that there has been some worsening in the lung diseases. The baby previously might have required lower PIPs to reach a set tidal volume and keep the lungs alveoli open, but now they are requiring a much higher pressure. It may even give us an idea of leak. So always look at the leak being displayed. And if it is more than 20 to 25%, please rectify. Check there can be a leakage at the ET tube site or in the ventilator circuit. And also if there has been an inadequate PEEP which was set, which was too low for what the baby might be requiring. A disconnection alarm indicates that there is something wrong with the circuit and you need to rectify and scan the entire circuit with big open eyes, because there are various hidden places where we can get these disconnections. Now let us see the minute volume, and it's very important to first understand what minute volume is. So minute volume is the volume of air inhaled or exhaled by the lungs per minute. So it is a product of the tidal volume and the respiratory rate. It's usually 200 to 300 ml per minute per kg. So what does low minute volume means? So a low minute volume means that the tidal volume or the rates have been very low. So here the lung is not expanding completely. There may be areas of atelectasis and there may be accompanied retention of CO2. So a low minute volume alarm may indicate that there has been a disconnection or leak, which prevents the tidal volume to be delivered. There is a blocked tube. Again, the tidal volume, the pressures, the volumes, whatever we are giving to the baby are not reaching the baby. There is a lack of respiratory drive. So the baby actually is breathing at the rates which have been set by the ventilator, and they may perhaps be low. Or there can be a worsening lung disease. So baby initially might require lesser pressures to reach the set minute volume, but now it is requiring higher pressures, and this indicates that maybe the primary condition may be worsening. Similarly, a high minute volume indicates that too much of tidal volume or too much of rates are being used by the baby. So this indicates that there has been some sort of overventilation and leading to hypocarbia. So the high minute volume in alarm may indicate that there is some auto-triggering. Auto-triggering could be because of leaks around the ET tube or the water which is in the circuit. It could also happen when there has been a rapid change in lung compliance. There was a stiff lung. It was requiring very high pressures to reach a tidal volume. And now we gave surfactant and the lung compliance improved. So here, now the set pressures are too high for the baby and there would be high minute volume allowed. Or thirdly, there has been inappropriate mode or rate. So here the baby is fairly okay. So we do not have to support every breath, which might be happening in this case. Similarly, the respiratory rate and high and low respiratory rate alarms are also very frequent in the ventilator. So the low respiratory rate alarm indicates that the baby is breathing perhaps at a very lower rate, so doesn't have a very good respiratory drive. And we should always look into the CNS causes in these cases. The backup rate that we have set has been very low. The tube has been blocked, or the chest is very stiff and is splinting the expansion. The high respiratory rate again indicates auto-triggering. High backup rate, which we have set, inappropriate trigger. So if the trigger has been very low, so most of the breaths are being supported by the ventilator. Again, that will lead to overventilation. Or if there has been a recent seizure leading to autonomic dysfunction. The ventilator also has a lot of numerical data, which I had already discussed in the previous two cases, which we discussed in the starting. So the PIP, again, the set PIP is very important, and we should always look at what is being delivered to the baby. Similarly, the tidal volume, and we have already discussed that it's very important to set the baby on volume guarantee modes and to set an appropriate PIP max. The percentage leaks, and that again gives us an idea of where that something may be wrong with the ET tube or the circuit, and then resistance. I would like to take a few minutes and explain this and get a little more applied knowledge in such cases. So let us see the normal ventilator waveform. So this is the pressure waveform. So here we have to just see that there is a PIP, which is the maximum inspiratory pressure, the peak inspiratory pressure, which dives down and leaves us with a PEEP, that is the peak end expiratory pressure. The area under this curve is the mean airway pressure. The flow waveform. So the flow waveform as the breath begins. So there is an inspiratory flow. This is an acceleration of the inspiratory flow, reaching the peak inspiratory flow. And then there is the decelerating inspiratory flow, followed by the accelerating and decelerating expiratory flow. So a flow curve will always have two loops, positive and negative. And this is the volume waveform. So here we see that the start of inspiration, a maximum inspired gas volume is reached, and then it is followed by end inspiratory volume. So now let us see and discuss a few scenarios. So scenario number one is a problem where it is with the infant or a blocked DT tube. So now here the pressure waveform, we see it's the normal. The PIP is reached, the PEEP is maintained. If you see the flow and the volume waveforms, they are significantly reduced. So what we are giving to the baby is not completely reaching the baby. So this indicates that either the tube is completely blocked, so the set parameters, they are not completely reaching the baby, or the lungs are too stiff and too non-compliant that they are not opening with the set flows. So again, the problem in such a case where you have reduced flows and volumes indicate a problem with the ET tube, where the ET tube is blocked, or a poorly opening lung. So it can be indicate severe disease. So coming to the next graph. So here if we see the pressure waveform, the flow waveform and the volume waveform are just going haywire. So here the pressures are sometimes delivered, sometimes they are not delivered. The PIP and the PEEP are not maintained. The flows, the inspiratory flow is not always followed by the expiratory flow, and we do not see any volume being delivered. So this simply indicates that there is a break in the circuit and you need to scan the circuit. Nothing is being delivered to the baby. The third and the last, here if we see the pressure waveform is the PEEP is there is some beaking in the PEEP, and then the PEEP is somewhat maintained. But if we see the flow waveform, there is no expiratory flow. The negative flow is not there. And again, in the volume graph, the volume waveform, the peak volume which has been reached is abruptly ends. So here the problem is around the ET tube. So there is inspiratory flow. The ventilator is working. The ventilator is giving through the entire circuits, is delivering the set pressures, flows to the baby. But there is something wrong with the ET tube, that there is leakage of air around the ET tube and the delivering no expiratory flow. So most likely the infant has extubated, or there is a disconnection in the ET in and near the ET tube. So after discussing the monitors, the ventilators, addressing the alarms and the waveforms, let us see the simple bedside things. The first is the history and examination. So as I have pointed out, it's very important to see the position of the ET tube and the appearance. Always check where the ET tube is fixed, whether it is appropriately fixed. Do we see any secretions or blockage in the ET tube? Is the misting visible in the ET tube? Look for the chest movements. Are the chest movements present? Is it unilateral? Is it absent? Hear the breath sounds. There could be decreased breath sounds on one side, increased on the right side, which indicates right main bronchus ventilation, or it could be significantly reduced. So it's very important to spend time with the baby, to look at the baby and examine the baby for all the detail. Then there are certain interventional assessments also which can be made, starting with number one, that is suctioning. So whenever you have the slightest doubt that the ET tube may be blocked and is evident by the surroundings, It's important to suction and see. And if there is an obstruction which was the cause of a desaturation, it will quickly resolve with suctioning. The other interventional assessment is by the transilluminator or the cold light. So it's a high intensity fiber optic cold light source, and it is a bedside tool to identify air leaks, particularly pneumothorax. Now, with this knowledge on the history, examination, chartings, blood gas, graphics, and x-rays, let us now dive into the bold peep. So a bad or worsening lung disease, so there will be something in the history. The baby may have required very high ventilator settings. There may be PPROM in the mother. There was no antenatal steroid which were covered. There may be, on examination, in such a case, you will find a bilaterally reduced air entry and very poor chest movements. The charts will always tell you progressive worsening instead of an acute event. There may be progressive increase in FiO2 and pressures and the ventilator settings. The blood gas will show respiratory acidosis. The graphics will show you low compliance with high resistance. And again, the X-ray will be suggestive of a bad lungs. With this, I would like to explain the compliance chart and the PV loop. So this is a very common loop which is seen on the ventilator graphics. And this gives us an idea of the compliance. So firstly, what is compliance? So compliance is the change in volumes which are brought about by a unit change in the pressures. So if less pressures are required to bring about good changes in the volume, it indicates that the compliance is good. So if pressures of 1 centimeters of water leads to 1 ml of increase in the tidal volume, the axis will be a very good standing loop with an axis at 45 degrees, indicating a normal lung compliance. As the compliance decreases, so there will be higher or more pressures that are required to bring about very small changes in the volume. So the graph will be pushed downwards and to the right. And if we see, the compliance will be significantly reduced and the graph is a sleeping graph. So this again, in this case where the lungs on the X-ray shows us a whiteout appearance and severe RTS, this might be the condition of the lungs with very low compliance, and post surfactants, this is what you get. An obstructed ET tube. So on history, there will be, the staff will be telling you that there are a lot of secretions or blood in the ET tube. There may be reduced air entry, a lot of conducted sounds and wheezing. The charts will tell you about frequent need for suctioning and rising FiO2s. The blood gas may show us respiratory to mixed acidosis if it's been happening for a longer time. The graphics will again be variable and with variable compliance and resistance and blunted flow. And the X-ray will be non-specific. So if you see the flow graphs, the flow waveform, the expiratory flow is reduced and the TE, which is the expiratory time, is increased. So for the lungs to complete, the alveoli to completely empty, it is taking in a lot of time and lot of effort. So this shows it that it's working against an obstruction. Similarly, in the flow volume curve, we see that the smooth appearance of the curve is now a little scooped. And this shows that the peak expiratory flow is also reduced and it is a scooped out pattern that is working against an obstruction. The long ET tube. So in history, you will get that the baby is never settling on a ventilator and is always fighting. On examination, you will specifically get reduced air entry on the left with poor chest movements. The charts will again tell you that there have been frequent desaturations and the baby was never happy on the ventilator. The blood gas will again show us respiratory acidosis. The graphics will show us a high resistance with less flows and volumes being delivered. And the X-ray may show us a collapse or hyperinflation. So this is an important loop in such cases where we see that the expiratory flow abruptly or prematurely ends, indicating a leak. Similarly, here also there is the leak. So displaced where will indicate movement times here was recent active gas maybe will show us that the ET tube is very high up. E, which stands for pneumothorax, coverage, a case of severe RDS or MAS, or there has been a need for aggressive resuscitation. Always when you have a pneumothorax, take the history of suctioning. So maybe suctioning was previously done with very high pressures, and that has what has led to an air leak. On examination, there will be asymmetry. There will be shift of the heart sounds, and the cold light would be testing positive. There will be sudden changes in the charts and worsening respiratory acidosis. The graphs will show us air trapping before the event, leak and autocycling, and the X-ray will show us a pneumothorax. So prior to a pneumothorax happening, this is the graph which gives us an idea of the hyperinflation. So again, this is the pressure volume loop. And in this pressure volume loop, the concept of beaking is made evident. So let us examine this loop. So let us examine it in two parts. So this is the part with fairly normal compliance, while this part is somewhat sleeping and the compliance has reduced. So the C20 to C ratio. So what is C20? It's compliance of the last 20% of the alveoli. And this compares the 20% of the compliance of 20% of the alveoli, the last 20% of the alveoli with the entire inflation limb. So as the lung approaches its the point of maximum distensibility, beyond which it will really give way and lead to an air leak. It approaches this phenomena which is called air leaking. So here again, with very large changes in the pressures, we can bring about very small changes in the volumes, and therefore the compliance has reduced drastically. Thus, the C20 to C ratio is always less than 1. And this indicates C20 to C ratio is also seen on the displayed parameters of the ventilator. And being less than 1 indicates hyperinflation and the phenomena of peaking, which can sometimes happen before the stage of pneumothorax. Coming to the equipment failure, in the history, again, there will be frequent alarms in the ventilator or water in the circuit. On examination, the baby will drastically improve on a TP's resuscitator. The charts will show us concerns over the ventilators. The blood gases were stable. The graphics may show us an obstructive pattern or the interference in the flow waves, and the X-rays would be non-specific. Lastly, coming to the equipment patient asynchrony. Here, it is a case of a bad lung, which or maybe a case where you have recently reduced sedation, On examination, the baby is very active, fighting the ventilator with variable chest movements with too much of retractions. The charts again show us frequent desaturations, high pain scores, tachycardia, and hypertension. The blood gases would be variable. Graphics again may show us beaking on the volume pressure loop, and the X-rays will again give us an idea of maybe the disease has worsened or there has been hyperinflation. So with this knowledge, now it is very important to act. So the most common steps whenever we have such a case and you are in doubt, disconnect the patient from the ventilator, connect it to the AMBU bag or a TP's resuscitator with 100% oxygen and start bagging. And then, if the baby improves, it is the problem with the ventilator or the circuit. And if it doesn't, it could be related to the infant or the ET tube. And now think the bold beep approach. So now let us follow a systematic approach and try to act accordingly. So now we have disconnected the patient and the baby is on bag and tube ventilation. So now the baby shows us some improvement. So it turns out to be the cause is the patient. Here, the second, but there is another cause and treat the second person, that is the ventilator. So always in such cases, there are three key points. There are two things that we need to observe. Observe the chest movements and observe the saturation. So if there has been poor chest movements and poor SpO2s, the problem lies with the tube or the lung. It could be a blocked ET tube, a displaced ET tube, pneumothorax, or a bronchospasm. So this baby is a baby who is not improving on our bag and tube ventilation. So now with the bag and tube ventilation, you see good chest movements, but still the saturations are poor. So it's always think of the circulation. Think of shock and PPHN. Thirdly, there is a scenario with good chest movements and good saturations. So here the problem could be in the ventilator or the lung. It could be a partial tube blockage, ventilator-related problems, partial tube blockage, or the primary disease may have worsened, and now the baby requires more pressures. So let us discuss each one of this in further detail and try to figure out a flowchart. So a case with poor chest movements and poor SpO2s. There is a scenario where you hear the breath sounds over the stomach and there is abdominal distension. So here it is a case of a dislodged tube and change the ET tube should be your first action. Now I do not hear any air entry. So that shows us the tube is totally blocked. And again, change sounds. The heart is to be shifted. I perform a cold light. It turns out to be a pneumothorax. So now act and start preparing for an ICD drainage. I hear a lot of wheezing. So then there can be a bronchospasm, which is again common in the preterm babies who've been ventilated long and for a BPD. And in these cases, bronchodilators may help. Coming to scenario 2, so whenever we have a poor chest movements and poor SpO2, the rule of the thumb is change the ET tube and trans-illuminate. Coming to scenario 2, wherein we have good chest movements with poor SpO2. So see if there has been shock along with the pallor and tachycardia. Think about IVH. The baby has shock. There has been white pulse pressure. There is a murmur that I can hear. There is tachycardia. Think of PDA. The baby is in shock and there is lethargy. The baby is not that active like it was in the morning and shows other systemic signs. Maybe is having bilious as aspirates and feed intolerance now. Think of sepsis. And lastly, this is a baby very labile, differential cyanosis, flip flop. Here, think of PPHN. And the last scenarios where you have a good chest movement and good SpO2. Now the baby requires the same pressures that it was previously. So it indicates that the problem is with the ventilator and you need to check that first. The baby is now requiring very higher pressures. So this indicates that either the tube may be partially blocked and you should think about suctioning, or the disease has further worsened or developed a complication, wherein the case you may need an X-ray as a tool. So now with this, I would like the chat box to be filled with answers according to these case scenarios. So this is a third case where a 30-weeker, 1.2 kg baby on assist control mode for RDS, it suddenly develops an SpO2 fall from 95 to 58%. There has been associated bradycardia. The BP is falling. There are alarms all around the NICU. The PIP rises from 18 to 32 centimeters of water. And the baby is not improving on TP's resuscitator, and there has been no chest movements. So what is your first action? What is your likely diagnosis? And what immediate intervention is required? I cannot open the chat box. So if anyone can unmute and answer these questions, so it will be good if we interact.
And immediately we remove the patient from ventilator and takes on bag or mask, ambu bag and your TP.
Hello.
Yes, so that we have already done. The baby doesn't show us any improvement on a TP's resuscitator, and we cannot appreciate any good chest movement.
Most likely it's pneumothorax because no any chest movements.
Yes.
So immediately we have to put ICT.
Yes, so that is the scenario. So here the baby has developed pneumothorax, and see if you have a cold light handy. Just see for the cold light test. Sometimes we can even put a butterfly and check. And if you don't want to wait for an X-ray, confirm with an X-ray and maybe place an ICD. Let us see the next case scenario. So this is a 40-week, 3.1 kg infant, which was born through meconium stained liquor on assist control mode. And the baby suddenly develops a fall in SpO2 to 75%. The apnea alarms, the low minute volume alarms are ringing. There is no significant chest rise, and we cannot hear any bilateral breath sounds. So what do we suspect in this case? And what intervention will be required? So we have apnea alarms and low minute ventilation alarms. Am I audible? Dr. Priyanka?
Yeah, I'm there.
Acha, I'm audible. Okay. I thought, yeah, just a minute. I'll just reshare.
Yeah, your screen is not visible. Yeah.
Is it visible now?
Yes, yes. Now it is visible.
Yeah, so this can be just a case where the tube may be blocked or displayed. And immediately in such a case, we need to take the baby on a bag and tube ventilation and assess, and the needful should be done. So the case 5 is a 32 weeks one support, now at 48 hours of life. This baby over the previous 4 hours has shown us progressive increase in pressures and FiO2s with desaturations. The CFT is borderline, and there is good chest rise, and bilateral breath sounds are also equal. So in this case, is this primarily a respiratory problem? So it doesn't look like that. What are differentials? So in this, when the baby has been put on bag and tube ventilation, and on the ventilator itself, there has been a good chest rise, and the breath sounds are also equal. So here, there can be a possibility that there has been a primary worsening of the respiratory problems, but more so we should be looking at the alternatives and the SIP, that is sepsis, IVH, and the PDA protocol, and act accordingly. So with this, I've just come to the end of the presentations, and the take-home messages from this presentation would be that always secure the airway, because that is the lifeline of the patient on ventilator. Always check the ventilator. Do not mute the alarms. Please look into the circuit disconnections and verify the settings in every shift. Monitor the baby continuously. Follow strict NICU charts where the vitals and the ventilatory parameters are written early. Always anticipate complications and recognize its early signs and act early. Think systematically, stay vigilant, and then save lives. And always, prevention is better than the cure. So it's very important to have a very nicely secured interface, timely suction only when required. So it should not be that we are just following suctioning every 3-4 hourlies. It should be done on need basis. You should be alert and monitor, and you should be alert enough to look into the various equipments and the monitors which are around the baby. There should be time to time simulation and training sessions that are conducted in the NICUs for the team response and skill development, and always try to extubate early. So now the teaching goes minimal intubation and early extubation whenever the baby is ready. So the smallest patients need the biggest team effort, and thus, whenever this tiny patient is showing us signs of an acute deterioration, it is very important to call for help. Take the help of the nursing staff and your team members and swiftly move in the direction of saving this child. At the end, I would like to thank the NICU nurses Thank you very much.
Thank you, Dr. Munmun. It was a very nice presentation. It was very systematic and crisp, very good to understand for a nurse, for a resident, for a doctor, equally well for everybody, I think. That was a very wonderful thing about the presentation, and case scenarios were very interesting. I would like to take up some questions. Dr. Amit sir is there, I think. So, sir is having excellent skills in ventilation. So, I would like to ask some questions to sir also. Sir, what are the common mistakes that you see during emergency management when a baby is deteriorating in NICU? What are the common mistakes you see?
Most common is not addressing the TABC in that order, and people rushing for searching for intubation, ET tube when simple positive pressure ventilation needs to be given, not addressing hypothermia as a cause in small babies. So, in emergency, whatever be the cause, be it seizures, be it pneumothorax, be it severe sepsis, severe HMD, severe MAS, and severe sepsis. Once the baby has crashed, then the principles of emergency management remain the same, irrespective of the cause. And if there is hypothermia, environment has to be made euthermic, and airway breathing circulation have to be addressed in that order. Positive pressure ventilation, as we have learned in NRP, is best given by the mask and your PPV bag, and that should be initiated because intubation, even if we are very adept at intubating, still it does take time. It requires more equipments. So this is the common mistake which I see often that people running for laryngoscope लेके आओ, ET tube लेके आओ, बगल में एम्बू बैग रखा है उसको छोड़े रखते हैं. That's what I would say.
Right. So preparation for a deterioration is important probably, that we should be prepared
Most
enough
often
for
babies
worst case scenario.
deteriorate without giving us time to prepare. They are usually, stable, and you last think that they would deteriorate. So universal precautions जैसे रहते हैं, वैसे ही
Right.
universal preparation के rules रहने चाहिए. Any baby who is on ventilator, CPAP can deteriorate at any time. So one has to be prepared all the time for such worsening. That is an important thing to remember.
Right. And one more question I would like to ask, sir. What should every NICU resident do in the first 60 seconds of sudden deterioration? If you need to tell 1, 2, and 3, and 4 things,
And dope are
should
four
every
things
NICU
that
resident
dope
should.
is to be remembered, that displaced tube and obstructed tube and pneumothorax and equipment failure. And these all four should be checked at in the same order. First step is if he is deteriorated, remove the baby ventilator and take the airway in your hands. So baby is already intubated, and uh, put the baby, remove the ventilator, take him on PPV, and give hand ventilation and look for chest rise. If chest rise is there, then it was a ventilator malfunction. Maybe some tubing has detached from its place from the. So check all the tubings from humidifier to ventilator inlet to the baby. And if there is still no movement on hand ventilation, then either the tube is displaced or there is some other local etiology, and then you go for that.
Right, sir. So dope and bolt peak probably has to be remembered by everyone and should be checked in that sequence. Thank you, sir.
Yes, my pleasure.
Thank you so much, sir. Thank you. Dr. Munmun, there is a question for you that which mode of ventilation they have asked, somebody has asked that which mode of ventilation and when to switch on to another mode, not related to this presentation, but would you like to answer it?
Okay, so we cannot say that there is like one mode is superior over the other, and so does the entire the various studies and everything. We cannot prove the superiority of one mode over the other. So it's very important to judge as per the baby, and it should be decided keeping the baby in mind. So if you have like a baby with bad lungs And here we want to support every breath of the baby with some backup rate. We just want it to be simple. We want to support the baby and we need to give them more pressures. So in such cases, it's better to follow the assessed control or the SIPPV, which we commonly say. Now, if there has been a baby, secondly, with maybe we are just ventilating the baby because of some neurological issues, and
ठीक है दवाएं शुरू कर दी और
so with some neurological issues. So in this cases, maybe an SIMV will also do the needful with the pressure supported ventilation. The key thing is now move towards using the VT and volume targeting and volume guarantees. So not using the VT along with whatever mode we use is actually a crime in the NICU. So we should, whatever mode we are comfortable with, it is also important to use the VT and set the tidal volume. Also, I saw a question on with the pulmonary hemorrhage. So addressing that case, here the baby who's already been on ventilator and is having massive pulmonary hemorrhage and the baby is bleeding. Yes, we cannot do a lot of suctioning, and suctioning should be and disconnections should be only carried on need to need basis when you see a lot of blood which is filled up in the ET tube. And if
Dr. Munmun, we are not able to hear you. I think she got disconnected.
She has lost the connection.
Akash sir, yeah. Sir, would you like to comment on anything?
Hello.
What common mistakes do you see?
I think already much has been said. The only thing is failing to prepare is preparing to fail.
Yeah,
We have always to be
right.
keep the resuscitation trolley, the drugs always ready, at least one per an ICU.
Yeah. Maybe simulation scenarios can be given to the junior staff, especially that how they are going to manage the things, because once the baby
Important
starts
thing is
deteriorating, everybody is running around.
don't depend on monitors, train your sisters well. They are the best monitors in your NICUs. If your level of nursing is good, nothing can surpass that.
True. True, sir.
If anybody else
Close
has,
the session.
then we can.
I think all the questions have been answered. Humidifier question already, I think, sir, you answered. Is it okay to connect ventilators without humidifier? So it is not okay at all to connect the ventilators without
So humidifier is
humidifier.
as important as setting PIP, PWP, FIR2.
Yes. Even if in
Don't-
a ventilator humidifier is there and it is not working, then the way you check the vitals of the baby, the way it should be seen that humidifier is working or not. In the daily rounds, there should be a checklist. Whether it is working or not, it is very important.
Is that quite often the humidifiers are not switched on, or
Yes.
the water has been filled initially, then they are not refilled. So they are equally important like your FIR2 and pressure valves. So ensure that your baby is seeing vomidified and humidified gases 24/7 whenever he is on ventilator, CPAP, or any other mode of respiratory support.
True. So all the questions have been answered, sir. So we'll close the session today.
Thank you, Dr. Priyanka. Thank you, Dr.
About-
Munmun. This
Yeah,
session.
thank you.
And thanks
Thank you for the opportunity, sir. Thank you so much.
for joining. Thank
Ashish,
you
sir,
for giving your words of wisdom. And with that, we end the night. Good night to everyone.
good night, sir. Good
Enjoy
night,
your
everyone.
and